Hi, my name is Jennifer Voigt, and this is my final DMP scholarly project presentation for Maryville University, Catherine McCauley School of Nursing. The title of my project is Taking a Stance Against Human Trafficking, a quality improvement project focused on the implementation of an evidence-based screening tool, process, and protocol in the emergency room to identify potential human trafficking victims. This is my committee. So my committee chair is Dr. Douglas Bartelt. My second reader is Teresa Galakatos. My community member is Molly Lewis, who is the clinical nurse manager for the Focus Hospital emergency room. And then the presenter is myself. So a little bit of background. So human trafficking is a global epidemic, and victims will often seek medical care while they're being trafficked. So the statistics show about in one study that about 88% of these victims encountered healthcare while they were being trafficked. 63.3% sought treatment solely from the emergency room. The reason being that they can kind of get in and out of the emergency room a little bit more unnoticed than if they were to try to establish with like a primary care or even go to an urgent care. The emergency room is more high volume, and they can kind of get in and out. So the traffickers prefer to take them there versus anywhere else. And then 76.9% of these individuals went unidentified as victims because of lack of inquiry. And so what that means is that staff didn't ask. Either there wasn't a good screening in place, or staff just didn't have the education to know how to ask the proper questions to identify these individuals. And in regards to self-identification, maybe these individuals didn't feel safe self-identifying due to their trafficker being next to them, or being in a little bit more of like an open space, not having the privacy that they needed. So 76.9% in this study of these individuals went unidentified. So emergency department staff in this same study felt like they lacked the knowledge and confidence to identify and care for victims of human trafficking properly. This project aimed to evaluate the effectiveness of utilizing an evidence-based screening tool in an ER setting to improve the detection of human trafficking. And the Focus Hospital that I worked with didn't have a reliable screening tool, process, or protocol in place for the staff to utilize to help identify trafficking victims. They had screening questions in place that were pretty broad, but this specific hospital serves a very large Hispanic migrant farm worker community. And so their screening tool that they had in place really just touched on abuse in general rather than focusing on human trafficking. And so they needed a better tool for the staff to utilize, and they didn't have any processes or protocols in place for what to do if somebody did identify as a victim. In the review of the literature, the 10 articles that were utilized were grouped into 4 common themes that helped to support the project. The first theme was human trafficking being a health crisis. So the business of human trafficking is a $150 billion industry with over 40.3 million victims worldwide. And when they say it's a $150 billion industry, they're talking about the resources utilized for healthcare and helping these individuals. The other common theme was trauma-informed care. So trauma-informed practices help create a safe environment and support patient-centered care. And then staff education needs. So in the study we talked about before, they identified that only 42% of these staff reported formal training regarding human trafficking, while over 93% truly believed they would benefit from some formal training. And then the last but not least was screening tools. So evidence-based tools were supported as being more effective than just provider judgment alone. So having a way to ask questions to help identify these individuals was far more effective than just a provider looking at somebody and stereotyping them into being a potential victim because of, certain tattoos or because they look disheveled. The screening tool is being proven as being more effective than that. So this quality improvement project focused on, it fit best within Lewin's force field analysis. So that included unfreezing, where recognizing the need for change and raising awareness of the gap in current practice. Moving, so developing new behaviors, processes, tools, EMR prompts, training, and staff engagement. And then refreezing, so stabilizing that change through policy and protocol updates, cultural integration, and reinforcement. So staff engagement, it's critical, right? It helps create buy-in and it helps to establish that firm foundation for your project. In regards to refreezing, we put in place those policies and protocols. We provided education to staff, and then it was reinforced with hard stops in the electronic medical record system for the screening questions, which we'll talk about moving forward. So the design was a quality improvement project, which was guided by the Plan, Do, Study, Act model. Quantitative data was retrieved from the Focus Hospital's EMR to complete a retrospective chart review. The chart review covered 6 months of pre-implementation data and 8 weeks of post-implementation data. So staff education included a mandatory virtual learning module, which they will receive as we move forward. They'll receive that yearly. And then a PowerPoint presentation that I did virtually during one of their staff meetings and was able to, in real time, educate the staff on the why behind the project, what the project structure looked like, what the new policies and procedures were and protocols, and then was able to answer questions, which really helped solidify the new project for them and helped them to feel much more comfortable with the idea that, their processes were going to change, because change is difficult, especially in an environment where everything's moving constantly and you rely on knowing your job really well. And so once you throw in a big change, it can really throw off your flow in a busy emergency room environment. So for intervention components, new evidence-based screening questions were created and they were utilized during the intake and triage process. A new process and protocol was put in place for identified patients. So that included having an algorithm for the staff to follow that showed them if this, then that, right? If the person identifies, then follow it to this. If they want help, follow it to this. If they don't, follow it to this. It was a really solid guide for the staff to not have to question what they needed to do next. It was written down very clearly for them. We put in place a red dot process for discrete self-identification. So this process included, there are signs in the bathroom that explain, like, if you are feeling unsafe, if you feel like you're being, hurt by somebody, that you just take this red dot sticker and you're going to place it on the underside of a urine specimen cup. And what that does is then the staff will see that and know that they need to take you aside. So if you came with somebody who could potentially be the person who's harming you, then we'll get you away from that individual to be able to ask those questions about abuse and potential trafficking in a private environment where you're going to feel safe and you're going to feel secure to talk about it. And you can then decide at that time if you would like further help from the staff and they'll follow the algorithm, or if you are just looking for resources, which we also created, which is the next bullet point, saying QR code resource list disguised as a care survey. So we created a business card that had on one side said, "Thank you for your visit today. Please take this survey." And there was a QR code for them to scan. So it's just a business card. Look like, how are we doing? How can we do better kind of survey. But when they scanned the QR code, it took them to an actual resource that they could utilize to contact when they're ready, if and when they're ready to seek help. And then there was a hard stop put in the electronic medical record. What that means is that the staff could not bypass the human trafficking screening questions. It had to be asked on every patient. Regardless, they couldn't move forward in the triage process until the questions were asked. So it helped make sure that we were gathering the information on every individual that presented to the ER for care, rather than just, missing people as they were coming through the doors. So participants included ED patients who presented for care during the study period, and this meant anybody who walked through those doors looking to be cared for in the emergency room. So the pre-implementation period was 6 months, from July 4th, 2025 to January 24th, 2026. And in that time frame, that ER saw 16,084 patients. The post-implementation period was only 8 weeks, and it was from March 5th to April 28th. And the ER saw 6,131 patients for a total of 22,215 encounters that were analyzed for this study. All patients who presented to the ED for care during the study period were able to participate in screening. So every one of them were asked the questions. We excluded post data collection, any infants or children that were unable to speak for themselves, and any elderly individuals 65 or older who were unable to speak for themselves. So we didn't include their data in the final data collection. Now, just to make sure to be of note that we still screened those individuals for potential abuse, because the emergency room had already had a protocol and screening in place for that. But that data wasn't included in the pre-implementation, post-implementation data that we used for the study, but we didn't ignore these individuals. They still got screened for potential abuse. So for data analysis, the variables and data source. So the primary outcome was the proportion of ED patients who identified as potentially being trafficked. The independent variable in the study was the implementation period, so the pre versus post implementation, that's 6 months versus 8 weeks. The dependent variable was the human trafficking identification status, so identified versus not identified, basically triggering a yes versus not. And then data were pulled from the electronic health record reports, which were generated by the hospital's information technology or IT department. For the statistical test, a one-tailed z-test for the difference between two independent proportions was selected because the outcome variable was categorical. Proportions were used rather than raw counts because the pre-implementation and post-implementation sample sizes were unequal. So in the results section, during the pre-implementation period, this Focus Hospital ER saw a total of 16,084 patients. During the post-implementation period, as we mentioned before, they saw 6,131 patients. The data, again, included all patients who presented to the ER for care during the 2 selected timeframes and who were screened for human trafficking. Out of the 16,084 patients seen during that 6-month pre-implementation period, 111 were identified as having a potential concern for human trafficking, which ultimately represented 0.69% of the ED encounters. Out of the 6,131 patients seen during the 8 weeks post-implementation, 63 individuals were identified as having a potential concern for human trafficking, which represented 1.03% of those ED encounters. The difference in identification proportions was 0.0034, which represented an absolute increase of 0.34 percentage points during that post-implementation period. And that reflected a relative increase of approximately 48.9% from the pre-implementation period to the post-implementation period. There was a 95% confidence interval for the difference in proportions, which indicated that the increase was unlikely to be related to random variation. And of note, because in the algorithm, once they are identified, they're connected with a local resource that was or that is focused on helping domestic violence, human trafficking, etc. And that's where they receive help post ER. And so I spoke with that business, and they stated that in that 6-month pre-implementation period, they had 2 confirmed human trafficking victims that were identified from the ER, provided the resource, and went to them for help. In the post-implementation period, in that 8 weeks post-implementing this project, they had 3 identified human trafficking victims. So even in that regard, this was a very successful project, and it's really exciting to see moving forward how it could potentially help so many individuals who don't have the opportunity to receive help otherwise. Some project limitations. This project was implemented in only 1 ER, which limits generalizability to other settings. The post-implementation period, it only covered 8 weeks, so the findings should be considered an early evaluation of effectiveness rather than evidence of long-term sustainability. The project design, it didn't evaluate each intervention component separately, so it wasn't possible to determine which component specifically had the greatest effect. And because the screening tool was new, formal reliability and validity testing haven't been completed yet. So aggregate reports didn't allow the researcher to determine whether the questions were asked consistently or under appropriate privacy conditions. I obviously wasn't there to see every single individual be asked these questions. So the limitations, they don't eliminate the value of the project, but they do shape how the findings should be interpreted. It was a very positive outcome for this project, but we should still take into consideration that, moving forward, should they continue to utilize it, there are a lot of things they could use to really establish how valid the project really is. So, answer to the project question, the overall findings answered the primary project question by showing a statistically significant increase in the proportion of patients identified following implementation. The increase from 0.69% to 1.03% really suggests that the structured process helped the ER staff better identify potential concerns. The EMR hard stop reduced the likelihood that screening questions would be left incomplete during that post-implementation period. And although the percentage point increase is small in absolute terms, it is important because human trafficking identification is a low frequency but really high risk patient safety concern. So overall, the screening, education, protocol development, and EMR workflow really worked together actually to improve that victim identification. So implications for practice, for nursing practice, providing that evidence-based tool and education to the staff resulted in better patient outcomes. ER staff needs to understand how to recognize victims and use correct tools so that these potential victims don't go unrecognized. And then well-prepared ER staff can work with the patients and help with what they are ready to seek help for. For the patients and healthcare community, the project supports patient safety, trauma-informed care, and a more consistent response to a very vulnerable population. Inclusive screening matters because trafficking can affect individuals across all ages, genders, race, nationality, social status, and type of exploitation. As I mentioned, this focus hospital has a very large Hispanic farm worker migrant population. And so, but this screening tool and process that we built will actually cover anybody, not just that population. And then the process can support teamwork between the staff in the emergency room and leadership. So in conclusion, for the project summary, the project showed a statistically significant increase in identification after implementation of the screening tool, the updated protocols, staff education, new processes, and the EMR hard stop. The impact is meaningful because potential trafficking victims who go unrecognized, they could lose an opportunity to seek help and address complex needs. And that doesn't mean just in that time. It means for the long term. Like if they don't get identified in that one moment, they may never have a chance to get help. So this project really focused on making a better environment for them to be identified or self-identify so that they can get the help that they need. Things that I would do differently, I would want to collect staff feedback on the confidence and workflow barriers. I want to see what's working, what's not working, how do they feel after the education, what can we do better. I'd want to evaluate long-term sustainability beyond the 8 weeks. It's nice to see that in 8 weeks we had a positive outcome, but I'd like to see what that looks like moving much further forward. And then complete reliability and validity testing of the screening tool. So I'd like to see, how well is that screening tool working? And then future plan and personal impact. So continue monitoring, periodic re-education, and protocol refinement. I do know that the Focus ER is planning to continue utilizing the process protocol screening tool, and they are looking to expand it out into the rest of the hospital and the sister clinics that the hospital owns. And so it is going to become a much bigger benefit to the community moving forward. But for our 8 weeks, we just focused on the emergency room only. So as I mentioned there, we want to explore expansion to other departments and clinics, which I know for a fact is their plan moving forward. And so this program, the DMP program, really strengthened my ability to connect clinical concerns, evidence, quality improvement, methods, and measurable outcomes. This was a very rewarding project to work on. It was nice to see that in 8 weeks we had such good outcomes, and I'm really grateful for having the opportunity to create something that is potentially going to help so many people moving forward. So I want to thank you all for your time and your dedication to helping us through this program, and I wish you all the best.